everyone, and welcome to our February edition of the Care Partner Meetup. I'm Polly Dawkins. I am the Executive Director of the Davis-Phinney Foundation, and I am joined by our monthly panelists, who some of you know and love, and we all do, as well as a guest speaker today. Without further ado, Connie Carpenter-Phinney.
Hi, everybody. All right, it's February. I like February. Not only is it my birthday month, but it's the month of Valentine's Day, and days are feeling longer. And I don't know, there's a lot of reasons to like February. So we're going to get after it today. We're also really lucky. February was made much brighter just knowing our special guest was going to be here today, because he's always such a font of information, and it's just so helpful to all of us. He asked before the talk, was this going to be sort of an individual therapy session or a group one? And I said, pretty big group, probably 150 of us, so that's okay. Anyway, but I'll get to Mark in a minute. I want to remind you, especially those of you who are new to our Care Partner Meetup here, that I am one of the founders of the Davis-Phinney Foundation, married to the other founder, and we have been living with Parkinson's in our house for more than 24 years. So there's that. Come by my PhD in this very, very honestly. Pat Donahue is also joining us. He is a school teacher in Las Vegas, in an office today during lunch hour. His wife, Sid, has Parkinson's disease, and we always welcome your input and honest comments. Pat, thanks for being here.
Thank you.
Yeah, and Gail Gittin, again, our angel from actually almost literally across the street from me here in Boulder, Colorado. Yes, she's got the halo on. Gail continues to step up for our Care Partner community. She lost her husband, Gene, to Parkinson's 3 years ago. And still just is also a font of information. So, this is a really unique group that we have here, including Polly Dawkins, who also knows quite a bit about Parkinson's. And so we're all going to be weighing in during this hour of power. But, Mark, we love having you join us because you bring your expertise, which is so rare and difficult to find, in our world of care partnering, caring for a person with Parkinson's, and that is the field of neuropsychology. Want to tell us a little bit about what that is and what you do?
Sure. Well, first of all, thank you, as always, for having me here. I really enjoy this group in particular and this team. The mission of the Davis-Phinney Foundation is near and dear to my heart. And I really, I'm grateful for the opportunity to come and be with you guys and educate people with Parkinson's disease and their caregivers and providers. So I'm a neuropsychologist, and that's a pretty rare breed in the US. There are only a couple thousand of us that do what I do. And a neuropsychologist is somebody who has a doctoral degree, typically in clinical psychology, who focuses on understanding the relationships between the physical structure of the brain and how it produces all of the emergent properties of the brain. Everything that we do as human beings, the way that we feel emotions, the way that we can think and plan, the way that we can remember things that happened in the past, the way that we can forecast things that are going to happen in the future. So everything that our wonderful brains do for us, and how the physical structure of the brain actually does it, from the cells to the connections of the neurons to everything in between, the chemicals. That's what I study. And my particular application is understanding how all of that works in a clinical setting. That is, when people use the word clinical, it means with patients. So I'm not studying brains in the lab, in tissues under a microscope, although I do that sometimes. Most of what I do is as I work in the clinic with real live walking, talking human beings and helping them to understand their behaviors, what's going well, what's not going well, And then what from that we can think about what brain areas are maybe not working the way that they should, and then of course which brain areas are working correctly. And then from that information, we can go ahead and give treatment plans for, well, listen, this seems to be the problem. I think it's because of your longstanding Parkinson's disease. Now let's think about ways that we can strategize to make that something you can live around. So that's kind of what I do in a nutshell.
Polly, I think you've got kind of a good question to lead us off. And then I know Gail's got a great one too. So let's dive in. And again, those of you that are new to Parkinson's, are new to this Care Partner Meetup, are new to any of this, it may feel daunting. You might not quite get it. You'd be like, my person's not experiencing that. And that is Parkinson's disease as well. You know, one person has a certain set of symptoms, another person has a completely different set. But again, we don't know what the road will look like for us. So this may be of help for you. And I hope it is. I really do. So Polly, what do you got?
Sure. So Mark, we would love to start with a clear, concise definition or description of the differences between mild cognitive impairment, MCI, Parkinson's disease, dementia, and Parkinson's disease psychosis. Can you help us understand those to set the framework for today?
Yeah, great starting point. I think it's always good to start off with a definition so we're all on the same page about what we're talking about. I'm going to add another topic there just because it kind of sets the stage, and that is, what is dementia? So I think you have to understand that before you can go into what is Parkinson's dementia, Parkinson's psychosis, and mild cognitive impairment. So dementia is a syndrome, meaning a constellation of symptoms or signs that come together under a certain pattern. And you might think of a set of signs or symptoms like a sniffly nose, a headache, body aches, and running a temperature. And that might consist of a syndrome of, for example, the flu, or a set of symptoms. But the cause for that might be many different things. It might be seasonal allergies. It might be the flu. It might be a cold or a virus. Lots of different things can cause that set of symptoms. So when we talk about dementia, dementia is a set of symptoms. And those symptoms are a change in cognitive function or behavior that is different from your previous level of functioning or behavior. That is to say, it's a change, something's worse. Not that you started off poorly and you're still poor, but rather you were good and now you're not so good. So it's a change in thinking or behavior that represents a decline from some previous ability, and that it impacts your daily functional abilities. So it's really clear that this has to have some sort of significance. So if you're having a change in thinking or behavior and it really doesn't impact you, that doesn't quite meet the definition of what a dementia is. Okay, so that's basically a dementia. And there's all kinds of different forms and causes. Parkinson's disease is one form of a dementia. Alzheimer's disease is another form or a cause of dementia. Multiple head injuries is another form, or chronic traumatic encephalopathy is another form of a dementia. Lots of different ways that you can get dementias, and Parkinson's disease dementia is just one of them. So now that gets us to mild cognitive impairment, which is something that people are hearing about more frequently these days because it's a rather new term. Basically, this represents a change in cognition or behavior that's different from where you were before, and we can actually see it on tests of thinking or memory, but it does not impact your daily functional capacities. That is to say, you can still do everything you need to do. You can live independently. You can pay your bills and your mortgage on time. You can go to the grocery store and get most of the things you need. You can live independently. So this is a change or an objective change in behavior or thinking that does not impact totally your functional capacities. Now, many people with MCI or mild cognitive impairment will go on to develop a dementia syndrome. That is to say, the cognitive changes progress significantly enough to impact functional activities. When it does, then you meet criteria for a dementia syndrome. And again, the causes might be varied. They can be Alzheimer's, Parkinson's dementia, CTE, lots of different things can cause that syndrome. So the real key point is how do these cognitive symptoms impact your functional abilities? That's the key difference between MCI or mild cognitive impairment and a dementia syndrome. Let me be clear, MCI is not normal aging. This is not just you're having some mild troubles and you're doing fine without it. MCI is something objective. We can actually measure it on tests.
So you can measure, and that would be something we as care partners would note, do you think? Or is it something that is pretty well hidden, or how would you know?
Yeah, I would say that by the time someone shows up in my office for an evaluation, both the patient and the care partner are noticing things that are quite obvious.
Okay.
So this is not the subtle slips of you walk into a room and say, oh, geez, why am I here? Or I set my wallet down someplace and now I can't find it. That's not what we're talking about here. We're talking about significant slips. So these are things you're going to notice in your person with Parkinson's disease. There's no question about it. And most of the time, it's the care partner who's bringing the patient to be evaluated, who's saying, listen, she's really starting to slip up and I'm noticing it. She's not quite aware of it, but I'm noticing that these things are happening. And then when I do my assessment, I note objective changes and say, geez, this is real. Something's going on here.
Okay.
So the last one you asked about is Parkinson's psychosis, which psychosis is really a disorder of thinking that usually has features that are characterized by things that we think are really a little unusual. And it's not just memory losses and that sort of thing. Rather, it's things like abnormal thoughts or behaviors. These might be delusions, which are thoughts in which you think something's happening or you misperceive or misinterpret the reasons for why things are happening. Common delusions are things like my spouse is cheating on me, or there's infidelity, or they're robbing me, they're going into my bank account and taking money when I don't want them to. These are common delusions that occur in Parkinson's disease psychosis. The other more flagrant features that you might see are related to visual or auditory function, meaning your person with Parkinson's might see things that aren't real. They might tell you that there's children in the house or small animals in the house, or that they saw something in the front yard when something is obviously not there. Oftentimes these are formed, meaning they're actual objects. They see children or animals or a person standing. Sometimes they're just movements, or they feel like something's moving in the periphery around them. Those are more visual misperceptions rather than true hallucinations. But oftentimes the psychosis is characterized by visual hallucinations, or less frequently, auditory hallucinations, meaning they're hearing things, typically voices or people speaking to them. That's not as common as the visual. So you often see visual hallucinations as being, when you do see hallucinations, they're visual. They're often formed of people or objects or animals or children. That might be of a loved one who's passed, that is coming and showing up at night. Oftentimes they're in low light when visual information is a little ambiguous.
Mark, does that usually occur because of medication, or that's also just part of the disease sometimes?
It's more frequently common after medication. Certain medications, the dopamine agonists that are not necessarily prescribed that often, but they still are out there, can precipitate, can cause these visual hallucinations in particular. That's not a good feature. Visual hallucinations are something you definitely want to tell your doctor about. If your person with Parkinson's is reporting these, you want to let their doctor know this right away, because they could potentially be frightened by these and do something that might harm themselves. They might, try and get away from them and run out into traffic. There's lots of things that could happen. So it's really a good idea to make sure your doctor knows about these things.
Right. Okay. Well, that's a really good primer, and I'm sure we've scared away a few people. I'm sorry. But it is so important to sort of understand the distinctions. And I know, Mark has spoken at some of our bigger events, and, we do talk about, of course, there's some memory loss with aging, and that's not what we're talking about. And I think that wants to be clear. And I think as the care partner, there's a lot of responsibility that we feel in terms of our capacity to actually understand and know when we should seek care. And I think, for example, if your person suddenly comes up with these symptoms after starting a new medication, you really need to make sure you get in touch with the doctor. And I think that's what Mark is saying as well. And this is a safety issue. Pat, yeah.
So I have a question for Dr. Mapstone. The there's a lot of people that aren't aware of what a neuropsychologist is, and may not have heard of the term before. Now we've met you and we understand from this experience today. Now, where do we get the referrals from to come and see a neuropsychologist? Is it normally the neurologist, or is it more often the movement disorder specialist, or is it a mixture of both?
Yeah, great question, and one that we frequently encounter. And this is a real barrier to getting proper and adequate care for your person with Parkinson's. I believe, I'm a little biased, but I believe that neuropsychological assessments and evaluations can be very helpful to first kind of let you know what's going on, to help you plan for what might be coming up, and then also to provide strategies for how to remediate some of these things. Most of the time, if you're in a community or an area where you're close enough to a major hospital or a tertiary care center, that is someplace that's got specialty care, not just primary care doctors or internists or general practitioners, as we call them, but rather specialists in neurology and subspecialists within neurology in movement disorders. So I am a subspecialist within the field of clinical psychology in neuropsychology. So what mostly happens is the referral comes from a secondary provider, that is a neurologist or a movement disorders doctor. So if you have access to either a neurologist or movement disorders doctor, you're 90% of the way there. You just got to make sure that you can get to a referral to come and see somebody like me. The problem, as I stated earlier, is there are less than like 10,000 of us in the country that are working in these centers, and many of us are in different fields and not, movement disorders. So there are very few. We're kind of rare. So it's hard to find us. That doesn't mean that you need to see someone who's specifically sub specializes like I do in movement disorders and memory disorders. Any good neuropsychologist is going to be able to do this sort of an evaluation that can give you information about your person with Parkinson's disease and their cognitive function. So the short answer to your question is I think most referrals come through your neurologist or movement disorder specialist. And I would say, as a patient, as a caregiver, be vocal. If you feel like this is something that you want and you want to have it help you, most neurologists are going to recognize that this is an important piece of the evaluation. If they don't, maybe you're not getting the best care you can possibly get. There are also other folks that do this other than neuropsychology, and that's rehab psychologists.
Oh, wow. I hadn't even heard of a rehab psychologist. Yeah. Wow. Yeah. And, but so I think it's clear. I think that everybody listen to that what he told us there is to be vocal. And I think exactly. that's really, we talk about that a lot on here, about being vocal and pressing forward. And if your movement disorder doc, your neurologist doesn't agree with you, go back to your family practice doc, because you'll probably find more agreement there, maybe sometime, But if you're in an area, if you're in a big urban area, you are more likely than not to find a neuropsychologist. And especially, Mark, you're affiliated with UC Irvine. I feel like probably a lot of neuropsychologists are affiliated with universities. Maybe I'm overestimating that, but probably quite a few. And so just, do the research yourself and say, I want a referral to this doctor, and push for it, because you know what, you, the care partner,
we're the front line. Yeah. And you see what's going on. And if the doctor is pushing you off or just not really paying attention to you, that's excellent. We need to speak up. We need to, you need to speak up and make yourself known. And that's just good. I've just been receiving a lot of different comments from individuals across the country on different things on this topic. And I just get upset when the neurologist, and I'm not picking on neurologists, but in this case, it was a neurologist that kind of pushed it aside, the dementia part or the MCI, would just push that aside and not really listen to the care partner. No, you need to listen.
But I think also, to be fair, when you go into the movement disorder appointment, you have so many things you're trying to work on, and they're just working on the tip of the iceberg most of the time. And that's why it's important to parcel this off into a different category. And I think that's really important, that you prioritize this as the care partner and say, okay, let's not try to solve that riddle at the movement disorder doc appointment. Let's go to a specialist for that. So I think 100%. You can find someone. It's like finding the right movement disorder doc. It takes trial and error, and it takes time. But if you suspect that you might need it, use your intuition and follow through on that. Gail, did you want to jump in with your question right now, or
Yes.
how should we go to the chat? Yeah, Gail, you have a good one. I know you do.
I've always been an advocate for care partners, and those of us who have been in the trenches for quite a few years, we know a lot of the behavior that we're dealing with. We know that. The big question we have is, do you have any suggestions on how we respond to that behavior? It's been most of the people that call me and give me questions about what should I do. It's not how to get a diagnosis. It's what to do with the diagnosis and how to balance your response to the person with Parkinson's when he is exhibiting behavior that is frustrating in so many different ways. Apathy is a huge one. Not wanting to tell family members so that you can get some support. Not wanting you to go with them to the doctor's offices. These are all behaviors that have to do with, emotions and psychology. So what do the care partner do when they have a person who is just uncooperative? How does a care partner deal with that and remind themselves that there's just so much energy that can be put out for something like this?
Yeah, Gail, that's such a wonderful question, and I'm really glad you brought that up, because it really gets to the heart of the experience, the lived experience of the people on this call as care partners that are in the trenches, that see these things on a daily basis and know that this is not the person that I've loved for 20, 30, 40, 50 years. It's a change that takes some both perspective, I think, and some education in order to deal with the right way. And I wish that I could give a blanket statement that's, here's how you deal with X, or here's how you deal with Y. There is no panacea. There's no general way to do these things. Each of these has got to be tailored to the individual, because we're all different, and your person with Parkinson's disease is going to need different things than Pat's person with Parkinson's disease. So it really is highly individual, and that's why a neuropsychologist or a psychologist is really very helpful, because this is what we're trained to do, is to help you problem solve about dealing with your specific person. And, all of the research that we do, all of the group studies that we do are based on group means. Groups of people with Parkinson's disease tend to respond this way to this intervention. That doesn't help when the person sitting across the couch from you, it doesn't fit that mold. And so what we really need to get to is this idea of tailored treatment, or what we're calling in the field precision medicine, for an individual, not groups of people. People with Parkinson's disease are not all the same. So to the heart of your question is really, I think that there are two key aspects. One is to recognize first that this is not your person with Parkinson's. This is the disease talking. This is the changes in behavior, the apathy, the obsessive. Oh, Connie, you've got something to say?
No, just stop and say that again, because that is so important. It actually brings tears to my eyes, because it's just, say it again.
Yeah.
This is not your person with Parkinson's.
Yeah.
I mean, this is your person with Parkinson's, but it's not the person that you know. I think it's so important to just hit that when you see that behavior.
I think it's an important thing, the very first step that a care partner needs to take is that you're dealing with a disease here. And what you're dealing with a disease through your person with Parkinson's disease. So it's going through the filter of the person that you've loved for however many years. But really what you're dealing with is the changes in the brain that the disease is causing. Yes. And that's what, if you take that mentality, it kind of takes out the idea that I'm hurting my partner or my spouse when I tell them these things, or they're doing this behavior and it frustrates me so much I want to yell and scream at them. you're not yelling and screaming at them, you're yelling and screaming at the disease. So I think that's the first big step in your mind, or barrier or hurdle that you got to get over is this is a different person now. And what I'm frustrated with is not my person, it's the disease that they have. It's the Parkinson's disease. So I think that's the first big step that mentally care partners really need to take into mind when they're starting this journey of care. The second, in my opinion, most important is education. And the more informed that you as a care partner are, the more that you can help your person as they struggle with the disease. And not to minimize, you are also struggling with this person's disease, but the person inside there is also struggling very, very much. And the recognition that if you know more about your enemy, you're going to be better prepared to deal with them. So if Parkinson's disease has certain features that you know are going to be manifest through your person with Parkinson's, the more that you know about that, the more that you can anticipate, the more you know the details of it, the more you really study it as kind of like a scientist, the more prepared you're going to be to deal with those problem behaviors. You mentioned apathy. That's a huge one. And again, there's no broad brush solution for apathy because it can take so many different forms, but it is certainly one of the more vexing problems in this particular disease, this apathy. I mean, we can go through individual recommendations that might work for your person that you can try. But just to say that I think that those are the two main things, Gail, and we're here as a resource as professionals to help you to get the education, to make that kind of mental jump to this is a disease, this is not the person anymore that I'm dealing with. I still need to have compassion and care and treat them with respect, but really I'm dealing with a disease here. So when certain behaviors happen, you kind of have to treat it like I'm not being mean to my husband by restricting these behaviors. It's the disease and it's my sanity as well that I need to keep, because if you're not in good health, you're not going to help them.
Yeah, it's the caregiver's sanity, because patience for so many years is a real challenge. And then, of course, that's associated with guilt. So it goes round and round. So then we all, as caregivers, think we have dementia because our brains are just so filled with all these emotions. It's hard for us to get through the struggle without losing our focus and ourselves and our person. So it's so important for the caregiver to understand that they're really dealing with something that is, well, I hate to use the word catastrophic, but when you put it all together, it's sad for both the person with Parkinson's and equally as sad for the caregiver.
And by extension, the families, the communities, the neighborhoods. I mean, these are not, individual diseases. These are diseases that affect broad swaths of our population. So yeah, I agree completely. And, my heart's out to all of the people as care partners who are dealing with these problem behaviors and seeing your loved ones change in ways that you didn't expect them to, or you didn't want them to. These are very, very difficult things, and getting help for yourself to whatever level you need that help, whether it's, going into therapy yourself to deal with some of these emotions, to vent, to say, I need a break, respite care. Just, I need a day where I'm not worrying about, my partner with Parkinson's disease, that I can go off and do something healthy, whether it's a hike or visit friends or visit a museum or whatever you need to recharge. It's so critical for that, because it's so difficult to deal with what you're dealing with. It's out of the normal experience.
The care partner is the most important person in your partner's life. So if the care partner isn't really pushing to take care of themselves, because they are the most important person, and they're giving their person with Parkinson's a gift to that person that could never be returned by their partner.
Absolutely. And I can tell you also, I just want to emphasize the point that your person with Parkinson's disease is doing the best that they can with the hand they've been dealt. And the behaviors that you see might not be on the outside, something that's something that you can understand or you want to see in your person, but they're doing the best that they can. And if that's a manifestation of the behavior that comes out at that moment in time, that's the best that they can do. And if you give them that grace up front, it'll pay dividends, and it's important to do that.
Yeah,
That's
and I want to drill that point home too, and then go to Polly for some questions in the chat, which there's been a lot, but I feel like one of the things that I really lean into is forgiveness. Sometimes to forgive myself for my behaviors because I've maybe lost my patience. So the doctor could write a prescription for us, just say forgiveness instead of, number of pills, or I'll write it for you. But it's also, to forgive them for some of their words or actions or lack of action. It can be very frustrating. And so to Mark's point, it may not be obvious that they're doing the best they can when you're living with someone 24/7, but if we give them that grace and we give ourselves a moment to forgive ourselves and to forgive the person, I think it's a really important quality to embrace and to think about and to allow yourself, because I don't think it's possible to live with the disease as a care partner without it. That's just my comment. Polly, what do we got? We're missing a lot of questions, and thank you everyone for all these questions.
So many questions. I think to start, Mark, it would be helpful to get an understanding of when and if a baseline neuropsych evaluation, when should that happen, or should it happen?
I think as early as possible. It's good to get a baseline. Most of the cognitive changes kind of go step by step with the motor changes. Not always, and that's not a hard and fast rule, but as you see the motor symptoms progress, which are visible, you can actually see the tremor, you can see the stiffness and difficulty walking and things like that. The risk for cognitive changes increases as those things get worse. So I would say once you start noticing significant changes in motor function, it's probably a good idea to get a baseline, because you want to anticipate there may be some cognitive changes in the foreseeable future, and you'd want to have a baseline. And a baseline is simply a set of tests that we use, and then we can compare in the future to see if things have changed. So a baseline, without a baseline, I don't meet my patients beforehand. I don't know what they're supposed to be doing on certain tests. And then if I get a result, I don't know if it's bad or not. So a baseline really does help. I would say as early in the process as you can.
Super. We have quite a few questions around, back to your definitions of mild cognitive impairment and all. Does a person with Parkinson's recognize that they have mild cognitive impairment or something on the dementia spectrum? Is there insight or awareness typically?
Typically, yeah. Although there are cases where they lack awareness or insight, and we call this agnostic nausea. But that's not so common in Parkinson's disease. We see it more frequently in Alzheimer's disease. Now, that doesn't mean that recognizing them and admitting to them are the same things, because a person with Parkinson's can recognize that they're failing in their memory or their planning abilities, but they may be defensive. They may not want to talk about it. They may want to hide it. They may want to, particularly in men, we're not very good about admitting weakness, particularly in this generation of men that can get Parkinson's these days. So there's a lot of things wrapped around that. But I think for the most part, if you really had an honest patient, yeah, they know it. They know something's going on, and it scares them. And it's that fear, that wanting to hide, that defensiveness that often keeps it so that people around them don't know until it becomes too obvious not to know.
Yeah.
Thank you. If somebody asks if my person is exercising and doing every physical thing that we can think he can do, will that help slow the cognitive decline?
Physical activity, is that what you're referring to? Yeah. So there clearly has been significant research in this area, because Parkinson's disease as a movement disorder, one might think that movement, and particularly aerobic exercise, would help some of the movements and being able to move around. And that clearly helps. The more that you're active and can move these muscles and keep them going, keep brain patterns of activity going, that's good for your movement abilities. There's also significant evidence that aerobic exercise helps brain activity and maintain brain function. And what it does is primarily, we think, through mechanisms related to improved cardiovascular function. So the more your brain gets its blood and oxygen from the heart, and the stronger your heart is in the vessels getting it to the brain, the better your brain's going to do. So your brain needs oxygen and it needs fuel. Fuel is glucose or sugar. So it gets those two things through the blood. And if you've got a better supply of blood getting it up there and taking it away, your brain's going to be happier and healthier. So for sure, exercise has been shown in humans, in laboratory animals, to definitely facilitate cognitive resilience to dementia and healthy cognitive aging, for sure. Now, that being said, I would say before you start any vigorous aerobic exercise plan, talk with your doctor to make sure you're healthy enough to do it.
What about other exercise, if you will, for the brain, mental activity? You've talked in the past about novelty for the brain. Can you talk a little bit about, people are asking about puzzles and mazes and games and Sudoku and
Yeah, I'm seeing that one right here from Amy. Yeah, wonderful set of questions. So the brain really likes to be stimulated. The brain likes to be active. The brain doesn't like inactivity. At the baseline state, your brain is always sort of firing and going off. So the brain likes to be stimulated, and the more directed you can put that activity into a task, the better it is in an organized way for your brain. So the cells in your brains are neurons principally, and they like to talk to each other. And the more neighbors that a neuron can talk to, the healthier your brain is. It creates these connections called synapses. And the more synapses you have, the more healthy your brain is, or resilient your brain is to any sort of disease. So the more robust your brain connections are, like a rainforest with all these trees in the canopy, the more of that you have, the more you can, accommodate for a tree falling down in a rainstorm. But if you have very few, then you're not getting those connections, and the cover isn't as great. So the more you can stimulate your brain, my principles are learn something new. So it's got to be something new. You can't just do things that you've always done, because that doesn't stimulate your brain. Your brain already knows how to do that. It's already seen that activity before. You got to find new things that stimulate you. You've got to challenge yourself. You can't, do the easy crossword puzzles if you like crossword puzzles. Go pull out the New York Times or something hard that's actually going to challenge you, where you really do have to think. So you've got to push yourself, just like when working out a muscle. You're not going to get benefit unless you push it a little bit. And then change it up, do different activities and do what you like. Don't sit down and do Sudoku if you hate Sudoku. That's like punishment. That's not going to help you. You're going to dread it. You're not going to like it. You're not going to get the benefit out of it. Find something you actually like to do and do that. And it's hard. It's very individual.
I was also, I read an article recently how, reading fiction, like complex fiction novels with a lot of characters, and maybe crossing, like historical fiction where you're trying to keep the time frame and the characters all, in order, know who they are, is really another good way, if you like to read, or if you're a person with Parkinson's likes to read, that these are other ways that I hadn't really thought about that really keep you, you're introduced to a whole new set of characters. You've got to keep them straight, all of that. So I think there's so many different ways that we can work on cognition for ourselves, because it's important for ourselves too, as care partners. And I think too, just as exercise is important for you, the care partner, and it's important for the person with Parkinson's, you don't always have to do those together too. If you don't have to be with your person, 24/7, you want to make sure that you're doing what you need for yourself. And it's very easy to feel very isolated and alone when you are in the care partner phase. And I think to feel depressed. And maybe we could speak to that a little bit too, Mark, because I think that's kind of cycle of isolation leading to depression is also, it also causes cognitive impairment that's probably transient, just because you get more fatigued, you just don't feel like you're thinking clearly, and it's just muddled thinking. I would like to talk about that a little bit too.
Sure. Yeah, that's a great point. The interplay between this movement disorder of Parkinson's disease, the cognitive effects, your thinking effects, and then also your mood effects as well. So these are the three areas, the holy trinity of the Parkinson's disease syndrome are movement, cognition, and emotional effects. And it's because the networks in the brain overlap at that point. So the ones that do emotion, the parts of your brain that do cognition, and the parts that do movement are all kind of overlapping at this one place in the brain that's not getting the right amount of activity and not doing so well. So you get these three kinds of symptoms. And so these non-motor symptoms have been under-recognized for a very long time, and now we're shining a light on this. But care partners have been telling this, and patients have been telling this for forever. They've known about this, but we're really in the scientific field just trying to understand this. So it's important, I think, to your question, Connie, is there's something we can do about depression. Doesn't have to be something that you suffer through. It's not something that you have to deal with. We have very good medicines for this. We have very good alternate treatments for this that can work in most people. It's a matter of finding the right ones that will work for you. But getting out of that cycle, which is a sort of, low motivation, the apathy, then into the depression that then feeds the apathy, and then all of these things, and getting sad about what's happening, needs to be broken. And I think that part of that is that patient care partner dyad is really the strength of that. And for people with Parkinson's disease who have an involved care partner, which clearly all of you on this call are interested enough to be here today, spend an hour listening to someone like me talk, this means you're interested. You've got a good foundation to build on. So I would recommend definitely that's something that can strengthen that interplay between the person with Parkinson's disease, their mood, but particularly depression, and then the sort of evolution of their symptoms. It's a really hard cycle to break, and sometimes you need outside intervention. You need a good therapist. You need medicines to help with the depression. It's really a challenge.
Yeah, I think again you're giving us that siren call to be active and to make sure we're looking at the whole person and our whole situation, not just little parts of it. We can't compartmentalize this, right? It affects everything.
Absolutely. You are now part of a team, whether you want to be or not. You're part of the team, and that includes your person with Parkinson's disease. It includes you. It includes your care providers, your neurologist, your GP, your psychologist, support that you get from the community. You can rely on these people. They're all working to help you.
Yeah.
With two questions around reading or listening to audio books, are those equivalent in terms of brain novelty and exercise for the brain?
Sure. I think it depends on engagement. I mean, how engaged. You can sit with an audio book on and not pay attention to it. That's not going to help you. But if you're actually following the story and listening to it, that's better than sitting there and watching TV and not thinking, or just sitting on the couch and looking out the window. So it kind of is like these activities. I saw someone put a comment. So my husband doing Wordle and Sudoku isn't helping, ? I don't mean to say that at all. That, although it might seem easy to the person, if that's enough to challenge them and get them thinking, it's better than nothing, one. And two, if they enjoy it, you just don't know what benefit they're going to get from it. So these things are without side effects. You're not going to get hurt by doing Wordle in the morning. So if it's something you enjoy, do the Wordle. I mean, it's better than not doing anything. But I would encourage you to try and stretch your muscles a little bit and go harder. Not to say Wordle wasn't hard. This morning's was really hard. But if you feel like that's too easy, push yourself a little bit more. Try and do something a little more challenging.
Yeah. Such a good point.
I don't want the caregiver to now put another burden on them to try to get that person with Parkinson's to do Wordle or do this or do that, because at the end of the day, it ends up being our job. We think it's our job to do as much as we can to keep this monster at bay. Sometimes it reminds me of the time I complained to my husband's speech therapist about his drooling. And she said to me, "Oh, I know how to take care of that. Just remind him to swallow." And I said to her, I started laughing. Remind him to swallow. So am I supposed to walk around all day long saying swallow, swallow? And then I looked up how many times a day a person swallows, and it would have been constant. That's all I would be saying to him. So I don't want the care partner with a person who has mild cognitive problems to now go and make it their job to get your individual to do all these challenging things.
Well, so Gail, I think the point there too is like we have to pick and choose, right?
Exactly.
And we've talked a lot on our Care Partner Meetup about recruiting other people to help.
Right.
So this is where your husband or your wife or your father's friend comes in and sits with them and does puzzles or plays board games, or you take them to, one thing that why the boxing is so important isn't just because they're boxing, it's because they're also doing some cognitive exercises while they're boxing. The rock steady boxing, for example, which is designed for people with Parkinson's, works on movement and cognition. So it is up to us to possibly have to structure that. But to your point, Gail, it's fatiguing. Like, how much can you, the care partner, carry? What kind of decisions can you make throughout the day that will lighten your load? And some of that, we've talked about this too, is scheduling, how important scheduling is for apathy. Because if something's on the calendar, you're not thinking, well, what should I do today? Your person with Parkinson's knows Tuesdays is rock steady boxing day. Thursdays is speech therapy, or whatever it is. You have a schedule. And so you probably have to set the schedule up. You have to set up transportation. But guess what? That might buy you some free time. And that's really important too, in the long run. And these are the things that we have to keep thinking about as we, move forward. And as the disease progresses, is think about yourself. What kind of time do I need? And how am I going to get it? And it's not going to come in a vacuum, it has to come with some careful thought and with a permission. We've got permission from our doctor to take care of ourselves. And it's so important, right? And so Mark, I have a question about that too. And I think we've talked about this before. Yeah, care partners typically come to the appointment with you or not?
Absolutely. I almost demand that they come with me. They often see things that are critical to my, assessments. They see things that the person with Parkinson's do not see or have insight towards. So absolutely. I treat the care partner as much as the patient with Parkinson's disease, because I'm really treating a dyad here. And the strength of one is going to support the strength of the other. So I like to educate, I like to assess, I like to, support all aspects of this. And I know it doesn't end when they leave my office, but I always give my card and I say, if you have any questions, you don't have to make an appointment. Just call me on the phone. Here's my cell phone. You can call me if you have issues. So I really want to make it a dialogue rather than just a straight, here's what you got to deal with. Go for it. Good luck. It's more of a, how can we get through this? And I'm providing support as I can. So yes, I always insist. And if I can get the children of the patient, adult children who want to come in and talk, I'm totally fine with that. I've had up to 10 or 12 people in a room at a time.
Oh, wow.
Yeah,
that's just like, that's kind of mind blowing that that you are sort of looking at that whole piece, and then also offering yourself, when the appointments aren't happening. I'm wondering how many people take you up on that. Is it too many or not very many?
Too many, but that's this is why I do this. This is why you'll find people like me doing this because they care, not because this is their job. And there's other places to do what I do, and I do this and I choose this population because it's meaningful to me. And don't undervalue that as a patient or a care partner. We really are here to help, and we're not here to just run you through and bill you. I mean, that's not what we do. That's not why we're here.
Wow, that's so important right there. Just think about that. I mean, that's a real team player right there. And that's what, I come from a sports background. I'm all about team. So I want you on my team, Mark. I know you are on my team, but
I'm on it.
It's just so important. And that's what's up to us. So whether you're new to being a care partner, whether you've been in this for a long time, or whether you're like in a really stable environment right now and everybody's kind of clicking along, you feel pretty good. It's never too early to start building these pieces. And as you know, and as the doctor said, even getting this assessment early, building a relationship with a neuropsychologist will only help you down the road and help answer those questions and sort out. It's a very confusing and confounding disease. And it's very hard sometimes to know what to do. And you know, we talk about so much that's happening, and some of you are like, I've never seen that. And that's normal that you haven't seen that, you know, but that's part of what's hard about the disease. So wow, thanks for that, Mark. I'm glad you're on my team. Polly, what are we missing as we get to the end? Or Pat or Gail, you have something pressing?
We have two questions that are sort of categories. One is, we've talked about physical activity and mental activity, cognitive activity. Are there medicines that can also help with neuropsych issues, cognitive issues?
Yeah, I saw that one scroll past about cognitive enhancers. At the moment, when we're talking about dementia, we now have some drugs that look promising for Alzheimer's dementia because they attack a specific part of the pathology in Alzheimer's disease. They are probably not ones that are going to be useful in Parkinson's dementia. So I want to just clarify that you may see in the news some dementia drugs are out there. They're probably not ones that would be useful in Parkinson's dementia. However, I did notice, and there are a couple of things that come to mind if your doctor wants to put your person with Parkinson's on a cognitive enhancer. There are different things like stimulants. If apathy is a problem, sometimes certain stimulants could be helpful, and either drugs that are wakefulness promoting agents. If you have sleepiness, if you're apathetic, they can give you a little bit of a stimulant. Those aren't necessarily things that are going to help you get smarter. We don't really have those things. We call them nootropics in the field, but they're, you know, we don't have good evidence that they do what they're supposed to do. So I'm not saying stay away from it, but I have yet to be convinced that there are real cognitive enhancers that can be particularly useful other than changing underlying behaviors. If he's apathetic and is sleeping all the time, well, then maybe a little something to keep him awake might be helpful, but that's probably not a cognitive enhancer. Might make him think a little bit better, but it's probably not doing,
Yeah, okay. That's a great answer, actually. And I think it's important, and it's, you know, there are a lot of people offering miracle cures for all kinds of cognitive stuff out there in the planet right now. And, you know, oh my goodness. Wow, we just have a couple more minutes. I want to also summarize a few things here and remind people that, yes, this is being taped or recorded and will be available to you and to your family. I mean, share this with them. It might really help if you have adult children or you know, anybody in your care team to listen to this and kind of hear the depth and breadth of it. I'd also suggest, you know, every month I do spend some time looking at the chat and at our transcribed talk and making a newsletter out of it so that we bookmark and remember what we've talked about. And I think that's important too, just to reread it, because if you're like me, you don't retain everything. It's another conversation, but we try. And so are there any last thoughts, Mark, that you would say are like the most helpful things that you can offer up? Or I do have a question, and that's about hope. It's actually like sort of this balancing act that we all have between hope and reality, right? Like we have to stay optimistic, but is that a fault to be too optimistic?
I don't think so. I think, you know, if you're avoiding, you know, things that are necessary because you're avoiding them, that's a little different from optimistic. But I think a good dose of optimism is really important as you go through this journey with your person with Parkinson's disease. You know, without hope, what else do we have? And sort of you want to make sure every day is the best you can be, and there are going to be days that you're not your best. There's going to be days when your partner is not the best, and you got to take those and move past. It's in the past.
Yeah.
But hope is important.
Yeah.
I find that hope comes in a lot of different forms. And it's not just a cure. It's not just, oh, today was better, but it could be that somebody came by the house to say hi and to bring you a treat or something. And, that all brings hope. And hope is a great thing.
Yeah.
I want to just say that for myself, it was very helpful to me to get out there with my husband. I went to boxing with Parkinson's, and that's tough. That's a tough class. I went to the spin classes. We went to book reviews. We went to walks, Parkinson's walk. We did all of those things together, which helped continue our relationship that we've established I was married 52 years. It's fun to get out there with them and meet other people in the Parkinson's community, and it'll elevate your mood.
Yes. Such a good point. Get out there and meet other people with
Get out
Parkinson's.
there and
Really
do it.
helpful.
Do it too. It's not that easy to go
Yeah.
boxing and spinning.
Yeah. Wow.
Yeah.
Mark, thank you so much for being with us.
Thank you,
my
Mark.
goodness.
You're welcome.